Welcome to this deep dive. We are jumping straight into the material today. No fluff, absolutely no wasted time.
Right, because if you're a resident preparing for board exams, specifically the FRCS and plastic surgery, you are in the exact right place.
Exactly. We are both plastic surgeons, and, well, we've designed this revision session as a rapid-fire tool to get you exam ready.
The format today is a direct question and explanation style. We just want to maximize your studying efficiency.
So the focus of today's deep dive is lower limb ulceration, and you really need to know this topic inside and out.
Oh, definitely. Leg ulcers are the most common chronic wounds in developed countries.
Yeah, they affect something like 1 to 3% of the British population, right?
Spot on. And that sheer volume makes this an extremely high-yield topic for the boards.
So let's get right to work. First up, we need a reliable, exam-ready framework. How do we classify the causes of leg ulceration?
Well, when the examiner asks for the causes, you want to immediately deploy the mnemonic vatamin.
Vatamin, V-A-T-I-M-A-N.
Exactly. It's comprehensive. It's easy to recall under the intense pressure of the exam, and it just covers all the etiological bases they expect you to demonstrate.
Let's break it down letter by letter. So the V stands for venous disease and the A stands for...
Arterial disease. Yeah. Those are your two most common culprits by a massive margin.
Venous and arterial are the obvious starting points. But stopping there is a guaranteed way to lose marks. We have to show a real breadth of knowledge across the entire spectrum.
Absolutely. So moving past the vascular issues, the T stands for trauma.
And for trauma, I mean, examiners aren't just looking for blunt force or a simple scrape, are they?
Mm-hmm.
What specific mechanisms do we need to articulate?
You really have to list several specific mechanisms to show you understand the nuances. So mention trophic ulcers, insect bites, and self-inflicted injuries.
Right.
But you also absolutely must include thermal trauma.
So burns and frostbite.
Exactly. And radiation-induced ulceration. Radiation is a classic mechanism that creates incredibly hostile wound beds. So mentioning it shows you're thinking like a reconstructive surgeon.
That perfectly covers the T. Next is I for infection. And we need to categorize the major pathogen groups here rather than just saying, bugs.
Yeah, please don't just say bugs. We're talking about bacterial infections, fungal infections, and mycobacterial infections.
And there's a specific infectious cause that candidates often forget, but examiners absolutely love to hear.
Oh, syphilis.
Yes.
Syphilis is the great imitator, so it always deserves a mention in any comprehensive differential.
But systemic issues go far beyond infections. That brings us to M for metabolic disorders.
Diabetes is the obvious anchor here, obviously. But if you want to score highly, you need to rattle off the metabolic zebras.
Right, the systemic issues that sort of sneak up on you. So you need to list necrobiosis, lipoidica diabeticorum.
And don't forget pyoderma gangrenosum. If you see a painful ulcer with an undermined border in a clinical scenario,
your mind should immediately jump to pyoderma gangrenosum.
Exactly. Then, to round out the metabolic category, you just have to confidently list porphyria, gout, and calciphylaxis.
Listing calciphylaxis shows a really solid grasp of the devastating metabolic etiologies. Then we hit the second A in the vitamin framework, which is autoimmune diseases.
For this one, start your list with vasculitis, then move into the connective tissue disorders. So systemic lupus erythematosus SLE and systemic sclerosis, which you might also know as scleroderma.
And finish that autoimmune category with rheumatoid arthritis and polyarteritis nodosa.
Which leaves us with N.
Neoplasia. And for us as plastic surgeons, neoplasia is absolutely crucial.
Yeah, if you're sitting for a plastic surgery board, missing this category is just catastrophic.
You must mention squamous cell carcinoma and specifically highlight the marginal ulcer arising in chronic wounds.
Spot on. Then complete the list with basal cell carcinoma, melanoma, Kaposi sarcoma, and lymphoma.
That completes the vitamin framework. Venous, arterial, trauma, infection, metabolic, autoimmune, and neoplasia.
Lock that acronym in your memory. Having that structure prevents you from freezing when the examiner asks an open-ended question about etiology.
Okay, let's translate that framework into the clinical assessment. When the patient is actually sitting right in front of you, or, when you're presented with a clinical scenario on the exam, what exact details do you need to extract during a patient history and physical examination?
Let's start with the history. The exact time of onset and the mechanism by which the ulcer started. Those are mandatory starting points.
And you have to document any and all previous treatments they've tried.
Yeah, you also need to ascertain their ambulatory status and the specific type of footwear they use.
Footwear is a detail candidates skip all the time.
All the time. But it is a critical environmental factor, especially for patients with neuropathy or arterial issues.
And along with their broader medical background, we must screen for relevant comorbidities. This ties directly back to our vitamin list.
Exactly. Diabetes and smoking history are paramount.
Crucially, the boards want to hear you ask about symptoms that point directly to an underlying cause. You must actively ask about claudication or rest pain.
Because those are massive red flags for arterial disease. If a patient mentions pain that wakes them up at night
Or pain that improves when they hang their leg over the side of the bed.
right, that is rest pain. And that dictates an entirely different clinical pathway.
That brings us to the physical examination. For the boards, we should structure our physical exam into 3 distinct pillars.
I like that approach. The first pillar is the examination of the ulcer itself.
Right, we're looking for physical features that suggest the etiology. For instance, venous ulcers are classically located in the gaiter area of the lower leg and typically have sloping edges.
Arterial ulcers, on the other hand, are usually found further distal, so on the toes, the feet, or the ankles. And they classically present with punched-out edges.
And tying back to the neoplasia category we just discussed, you must always explicitly state to the examiner that you are actively looking for features of malignancy.
In both the ulcer bed and the margins. Always say that.
That's pillar 1, the ulcer. The second pillar is the state of the circulation.
We need to check the local temperature of the limb and the capillary refill time. We must palpate the peripheral pulses.
Furthermore, we're actively looking for signs of underlying venous disease in the surrounding tissues.
This means checking the limb for varicose veins, generalized edema, venous eczema, and hyperpigmentation.
If you see those signs, you're building a strong case for a venous etiology before you even order a single test.
And the third pillar of the examination is sensation. We must assess the patient's sensory functions.
Specifically, we're looking for a glove and stocking pattern of sensory loss.
Yeah, if you find that glove and stocking sensory loss, it strongly suggests underlying peripheral neuropathy.
Which feeds right back into your metabolic etiology list, particularly diabetes.
Exactly. It means the patient lacks protective sensation, making them highly vulnerable to trauma.
So to recap the exam structure, the ulcer itself, the circulation, and the sensation. Once we have completed a thorough history and physical, we need to order investigations to complete the workup. What's the definitive list of investigations we must order?
Start with microbiology wound swabs to identify any colonizing or infecting organisms.
Next, you must calculate the ankylobrachial pressure index, or ABPI. That is totally non-negotiable.
You cannot safely apply compression therapy without knowing the ABPI, full stop. Following that, order formal vascular studies to map the anatomy and flow.
For radiology, we need to request X-rays, a CT scan, and bone scans.
The specific goal here is to assess if there is any bony involvement underlying the ulcer. If the ulcer probes to bone, or if the imaging shows bone destruction, you're dealing with a much more complex scenario.
Then there is the biopsy. You must state to the examiner that a biopsy is an absolute necessity for long-standing ulcers to definitively exclude malignancy.
Finally, remember your multidisciplinary team approach. Mention an onward referral to a rheumatologist if you suspect vasculitis or a connective tissue disorder based on your clinical assessment.
Let's drill down into the specifics of the 2 major categories, starting with venous disease. Venous ulcers account for a massive 80% of all lower limb ulcerations.
So we need to completely break down the pathogenesis and management.
By definition, a venous ulcer is an area of epidermal discontinuity that persists for 4 weeks or more.
And that discontinuity occurs as a direct result of venous hypertension, combined with insufficiency of the calf muscle pump.
There are 3 main mechanisms driving that hypertension that you need to cite. First, reflux of venous blood due to valvular incompetence.
And this valvular incompetence usually occurs secondary to thrombophlebitis, a previous thrombosis, or direct trauma to the limb.
The second mechanism is direct venous obstruction. And the third is general insufficiency of the calf muscle pump itself.
This pathology can affect the superficial system, like the long and short saphenous veins, the deep system, or the interconnecting perforators.
The micropathophysiciology is where candidates often lose points. The pathogenesis isn't entirely perfectly understood, but there are specific mooted mechanisms you absolutely must know to show deep understanding.
It starts when venous hypertension causes a protein-rich exudate to leak out into the subcutaneous tissue.
That exudate forms a pericapillary fibrin cuff. This cuff is the primary villain here.
It really is. It creates a physical barrier that blocks oxygen transfer, causing local tissue hypoxia. You have a microscopic environment that is literally starving the tissue of oxygen.
But the hypoxia from the fibrin cuff is only half the story. The venous hypertension also causes extravasation of red blood cells.
When these erythrocytes break down in the tissue, they trigger a severe inflammatory response.
This leads to the deposition of hemosiderin within macrophages, which gives the skin that characteristic brownish staining.
Furthermore, transforming growth factor beta, or TGF-beta, is released. This cytokine is thought to mediate dermal fibrosis.
That fibrosis leads directly to lipodermatosclerosis, and eventually the skin breaks down into an ulcer.
If you're asked to describe the clinical presentation of lipodermatosclerosis, tell the examiner it is characterized by intense scarring, fibrotic, and hyperpigmented skin.
Because of the fibrosis in the lower leg and the edema above it, it gives the leg a classic inverted champagne bottle appearance.
That brings us to management, starting with non-operative treatments.
Compression is the absolute gold standard treatment for venous ulcers. It must be used continuously until healing occurs.
For the exam, you should know the numbers. The mean time to healing with optimal compression is 5 months.
However, be prepared to quote the recurrence rate. Even with gold standard treatment, there is a 30% ulcer recurrence rate within 5 years.
It's a really frustrating reality of this disease process.
When discussing the practical application of compression, the 4-layer bandaging system enables the shortest time to healing.
You apply these 4 layers from the toes all the way up to the knee.
The layers in order are orthopedic wool, followed by a crete bandage, then an elastic bandage, and finally a cohesive retaining layer.
Now, patients usually prefer compression stockings because they're certainly easier to use, but there's limited evidence showing they're superior to the 4-layer bandaging for actual ulcer healing.
If you are discussing stockings, you need to know the classifications based on pressure. Class 1 is light compression, providing 14 to 17 millimeters of mercury.
Class 2 is medium, providing 18 to 24 millimeters of mercury. And Class 3 is strong compression at 25 to 35 millimeters of mercury.
Aside from compression, we should mention pharmacological treatments. Pentoxifylline is the key drug here.
Just be sure to note to the examiner that its use for venous ulcers is an unlicensed indication.
Finally, for non-operative management, you can mention bed rest and leg elevation, but acknowledge that this is highly impractical for most patients, and the ulceration tends to recur the very moment they resume normal ambulation.
So, when do we, as surgeons, actually operate on a venous ulcer? That's a critical point.
Venous ulceration is not usually managed surgically as a first-line treatment. The indications for surgery are strict.
You operate if there is intractable pain, if non-operative treatment has completely failed after a significant period, or if there is specifically surgically treatable venous disease.
And we must remember that surgery has to address both the underlying venous disease and the ulcer itself.
To treat the underlying venous disease surgically, we can perform ablation of the superficial and perforating veins.
This is achieved either by open surgery or endovenous laser ablation.
There is also SCPS, which stands for subfascial endoscopic perforating vein surgery, and in some more complex cases, reconstruction of the deep venous system is required.
When it comes to operating on the ulcer itself, the standard approach is debridement and skin grafting.
But there is a huge warning you must state to the examiner. There is a very high recurrence rate for the graft if the underlying venous pathology is not corrected first.
In exceptional circumstances, you might perform an excision of the ulcer with flap reconstruction, utilizing either pedicled or free flaps.
But again, that is strictly reserved for exceptional cases where simply reconstructive ladders have failed.
Let's pivot and contrast this with arterial ulcer disease. Arterial ulcer disease results directly from a reduced blood supply to the lower limb.
The most common cause, by far, is atherosclerosis.
You need to quickly list the risk factors for atherosclerosis: advancing age, a family history, smoking, diabetes, hypertension, hyperlipidemia, and obesity.
The clinical picture of an ischemic limb is very distinct from a venous limb. You'll see dusky erythema and a significantly lower surface temperature compared to the rest of the body.
There will be a lack of hair growth, and the skin will appear thin, brittle, and atrophic.
The toenails are often thickened or missing entirely, and critically, the peripheral pulses will be absent.
Now, there's a crucial warning we need to highlight regarding how arterial ulcers begin and how we handle them.
Clinical scenarios we see on the wards constantly remind us that severe arterial ulceration can develop after seemingly trivial trauma.
Because the tissue has absolutely zero vascular reserve, a minor scrape can cause a rapidly expanding, non-healing wound. Patients must be taught meticulous skin care to avoid this.
But the most important warning for you as a surgeon is this. Aggressive debridement or the application of negative pressure wound therapy can actually enlarge the area of ischemia.
This is a massive board trap.
Mhm.
You can make the wound significantly worse if you debride an arterial ulcer without first restoring blood flow.
Management is a combination of operative and non-operative methods. Non-operative management focuses entirely on controlling those modifiable risk factors we mentioned.
Like aggressively managing diabetes and stopping smoking.
You also implement a graded exercise regime, strict foot care, and infection prevention. Pharmacologically, you can use cilostazol or pentoxifylline to help with symptoms.
But when do we intervene operatively? The strict indications for operative management in arterial disease are non-healing ulceration, the presence of gangrene, rest pain, or the progression of disabling claudication.
The primary aim of surgery here is simply to improve blood flow into the affected limb. Restoring perfusion is the only way to accelerate the healing time.
This is achieved either through reconstructive vascular surgery, like a bypass, or via endovascular angioplasty. Once the blood flow is restored, the tissue actually has a chance to heal.
If we connect all of this to the bigger picture, I want to leave you with a higher level concept to mull over regarding everything we've discussed today.
Let's for it.
We talked extensively about how the microscopic environment, like that paracapillary fibrin cuff, causes local hypoxia and venous disease, making the wound bed incredibly hostile. Well, consider how that microscopic environment fundamentally dictates the success or failure of our macroscopic physical surgical interventions like skin grafting. The takeaway here is simple but profound. You cannot outoperate bad local tissue oxygenation.
That is exactly the kind of forward-thinking perspective that separates a passing candidate from a stellar one. All right, that is our rapid-fire deep dive on lower limb ulceration. If you learned something valuable for your exam prep today, please hit follow on the show right now so you don't miss our upcoming revision deep dives. And take a second to rate the show.
Yes, please do.
Also, make sure you get a premium subscription. That subscription gives you exclusive access to our premium journal club and clinical cases episodes, which are absolutely vital for rounding out your board prep. Finally, we want to hear from you. Leave a comment or a question about today's material wherever you are listening. Keep studying hard, and we will catch you in the next session.